Hi students, this is Dr. Hartley. I'm going to go over a brief review of heart failure. The first thing to remember is that heart failure is a syndrome, so it's a group of characteristics, signs, symptoms, and diagnostic findings with a variety of underlying causes. So there is no one cause of heart failure. There are many different causes of this syndrome. Clinically, we group heart failure into two main categories. The first is heart failure with preserved ejection fraction, and the other is heart failure with reduced ejection fraction. So the cutoff for this is an EF of greater than or equal to 50%, and the signs and symptoms of heart failure characterizes the patient as having heart failure with preserved ejection fraction, whereas an EF of less than 40% is heart failure with reduced ejection fraction. Normal ejection fraction is actually around 55 to 60%, and you can see that there's a decent amount of gray area between these two, so there is like kind of an intermediate category between these two types of heart failure, but we're just going to ignore that for now. So we're just going to keep things simple and describe heart failure with preserved ejection fraction as being purely a diastolic problem. So there's a problem filling the left ventricle during diastole, whereas heart failure with reduced ejection fraction, there's a problem during systole. In reality, this is a bit of an artificial separation because you can have syndromes or patients who can have actually both diastolic and systolic problems. These are really like echocardiographic findings. So it's cardiologists looking at the way the ventricle contracts and looking at the way the ventricle relaxes and complex equations and the way the blood is moving. So you can actually have these two things happening at the same time, but I think we can just really put that aside for now. If you want to talk more about it, then see me or send me a message. But for now, we're going to describe heart failure with preserved ejection fraction as being a diastolic problem and reduced ejection fraction as being a systolic problem, and I think it will work for the most part. So in heart failure with preserved ejection fraction, you're not having problems during systole. You have normal contractility. You're not having problems contracting the ventricle and getting the ventricle to empty. You're actually having problems filling it. Whereas in systolic heart failure, you have reduced contractility. You're having problem during systole contracting the left ventricle. You have a loss of contractility. So remember that contractility is not the same thing as the Frank-Starling effect. The Frank-Starling effect is what Dr. Shannon talks about, how when you increased central venous pressure up to a certain point, you're going to actually increase cardiac output. So increased stretch of the left ventricle results in increased cardiac output. You do still have that even in systolic heart failure where you have a loss of contractility. You do still have an increase in cardiac output up to a certain point with increased filling. It's just not enough to compensate for the loss of contractility. You can see that we're operating at a lower cardiac output even with the same amount of filling pressure. So I think heart failure with reduced ejection fraction with the loss of contractility and impaired pumping function is a little more intuitive to understand than heart failure with preserved ejection fraction. So to clarify this, I think it's useful to talk about the end-diastolic volume. The end-diastolic volume is synonymous with preload. So it's the amount of blood in the left ventricle right before systole. So there's been some confusion because in some of your board prep books, there are notes that the end diastolic volume can be normal in heart failure with preserved ejection fraction. That is true. You can have normal preload, which then can actually result in a normal stroke volume and even a normal cardiac output. How is that possible when you know you have a patient with heart failure and you're saying that the volumes are normal in the left side of the heart and that even the stroke volume and the cardiac output is normal? Well, the problem is that this all happens at the expense of increased pressures. So if you're thinking about increased pressures in the left heart during diastole, so during filling, the left ventricle is continuous with the left atrium because the mitral valve is open. So the pressure gets transmitted back through the left atrium into the pulmonary vasculature, and that is what's causing the pulmonary symptoms and signs in patients with heart failure with preserved ejection fractions. Even if you're having normal volumes on the left side of the heart, you're still getting those backward symptoms of heart failure, and you're getting pulmonary edema, interstitial edema, dyspnea, hypoxemia, and all of that. And if you remember from the congenital heart disease lectures, the pulmonary vasculature does not deal well with increased pressures. It's meant to be a low pressure system. And so over time, if you're operating at higher pressures in the lungs, that gets transmitted back into this vessel here, which is the pulmonary artery. And high pressures in the pulmonary artery is we call that pulmonary hypertension. So then you have the right heart pumping, which is not a muscular chamber, pumping against elevated pressures in the pulmonary artery, and over time then the right heart is going to fail. And so you can see in this system, even in a patient with heart failure with preserved ejection fractions with normal volumes in the left side of the heart, you're getting all these backward symptoms due to increased pressure into the pulmonary vasculature, which then can lead to irreversible changes in the pulmonary artery, which we call pulmonary hypertension, and then eventually lead to right heart failure. Now, you can have lower volumes than normal as well in heart failure with preserved ejection fraction. So this can be low. You could have low or normal and diastolic volume. And if you remember that ejection fraction equals stroke volume over the total amount of blood at the beginning of systole in the left ventricle, which is end diastolic volume or preload, same thing. If you have a lower end diastolic volume because you're having trouble filling the left ventricle, but you still have normal contractility, then your stroke volume is going to go down by about the same amount as the preload. So these two will kind of cancel each other out, and you'll have a, quote, normal EF, which is what we're talking about here. We're talking about heart failure with preserved ejection fraction with a normal ejection fraction. So in this situation, even though your EF looks normal, you may have a low cardiac output, slightly low, but it can be even normal, which is what we talked about before, but at the expense of higher pressures in the left side of the heart. The situation in heart failure with reduced ejection fraction is very, very different. It is a systolic problem. You have loss of contractility in the left ventricle. You are not emptying the left ventricle normally. So your end diastolic volumes will be high. You have elevated preloads in heart failure with reduced ejection fraction. So if you have elevated volumes in the left ventricle, those elevated volumes will elevate the pressures, and some of that volume and pressure does get transmitted back into the lungs, and you end up with a pulmonary symptoms, just like you did in heart failure with preserved ejection fraction. Now, in heart failure with reduced ejection fraction, you definitely have low cardiac output because you have a systolic problem, so your stroke volume goes down pretty dramatically. That's what we're saying when we have a reduced ejection fraction. That's going to lower your cardiac output. So you have symptoms of forward failure and backward failure in heart failure with a reduced ejection fraction, whereas in heart failure with preserved ejection fraction, you're primarily, at least initially, having, or if it's a pressure problem, having symptoms of backward failure into the lungs. If you have normal cardiac output over here, you're still perfusing your organs for the most part. Whereas in heart failure with reduced ejection fraction, you have the loss of contractility, you definitely have loss of cardiac output, and so you have symptoms of forward failure, meaning you're not perfusing your tissues and your organs. So how do you know which type of heart failure your patient has? Well, you ultimately diagnose these two based on the echocardiogram. However, there can be signs on physical exam which may give you a clue. One of those is blood pressure. The blood pressure in heart failure with preserved ejection fraction tends to be normal or often even high. So these patients may be hypertensive, they may be normotensive. They're not likely to be hypotensive unless they're ill for some other reason or dehydrated or something. Whereas in patients with heart failure with reduced ejection fraction, they often will have a normal, even quite low blood pressure. And that's because they just don't have enough cardiac output to maintain that mean arterial pressure. So these patients often live at a blood pressure, can be even in the hundreds or 90s over 60s, depending on how low the EF is. Once you get an EF of around, 10% or 5, 10, 15%, they may live at quite a low blood pressure. And of course, then we start treating them with ACE inhibitors and beta blockers, which you need to improve their chance of living. But then you're going to drop the blood pressure even more. So you often see a low blood pressure in these patients. Another clue can be extra heart sounds. So in diastolic heart failure, remember that you will often have an S4, whereas in systolic heart failure, you will often have an S3. It's not a hard and fast rule, but if you have these things, a low blood pressure or an S3 or a hypertensive patient or an S4, that can help you further categorize the patient and make a guess even before you have your echocardiogram results.